calcium, phosphorus, vitamin D, and vitamin K testing. So let's jump into how do we look at calcium and phosphorus. So the important thing to remember is that when we have a CMP, we are going to have a standardized set of indices. And most of these are not only looking at the electrolyte balance for serum, which is tightly under regulatory control mechanisms. However, it also gives us an idea of renal function because it's up to the nephron under different signals to resorb certain nutrients, and that includes many of our electrolytes. However, potassium is not resorbed, and as we're going to see here, we're looking at calcium and phosphorus in regards to the CMP. And we want to recognize that calcium is under tight hormonal control in the serum, which is on our standardized CMP or our metabolic chem panel 14. However, serum phosphorus is not. You would have to do an add-on if you wanted to monitor phosphorus. Again, as I have said in the past, I think that it is a criminal act to not have phosphorus because it's vitally important when we're looking at some of the mechanisms for bone regulation. It's also important for bone de and remineralization. So first and foremost, you need to recognize that the CMP does not include calcium. However, when the hormonal regulatory mechanisms act at the level of the nephron, both phosphorus and calcium are going to be acted on. So we'll take a look and see what that shows. So what physiological constituents demineralize bone versus remineralize bone? And then what are the control and regulatory mechanisms, as well as the stimuli? So under calcium and phosphorus regulatory mechanisms, it's going to first be important to remember that the teeth and bone are a complex of calcium plus phosphate in a molecule matrix called hydroxyapatite. In addition, the calcium has its own other functions, very important cell signaler, and this is why calcium at hypercalcemia levels can become a problem because it can irritate some of the second messenger mechanisms and cause symptoms. And then phosphate also has its own, here's some of the cell signaling. And if you recall, just a quick review, the calcium is so potent of a second messenger that once it gets inside the cell, it stimulates its purpose, whatever it's needed, and it's intracellularly. And then there are several mechanisms to make sure that that calcium is kicked right back out. That's what this is demonstrating. And this is why hypercalcemia can become a problem. So quickly looking at the other mechanisms of phosphorus, which is again why hyperphosphatemia can become a problem, is that the phosphorus acts at multiple different levels of additional functional roles outside of the hydroxyapatite. So the physiological mechanisms, and these are important to understand, that that phosphorus acts at the level of your creatine phosphate. It's also the phosphate source for your DNA, pentose, the backbones of the nuclear material. It also is important in the carbonic deanhydrase reactions where the hemoglobin to deliver the oxygen, and very important, as we will recognize in the next lecture, for electrolyte and acid-base reactions. The intracellular phosphorus is a very, very important buffer. However, moving on to answer the question here for the mechanisms of monitoring the hormonal regulation, we are going to see that demineralization is going to be under the control of your parathyroid hormone and your active vitamin D, your 125 calcitriol. 125 is your active vitamin D. Together, parathyroid hormone, our PTH, and our active vitamin D calcitriol are going to demineralize bone. Now, why is it doing this? The stimulus for demineralizing bone is a drop in calcium. A drop in calcium is a signal to the parathyroid gland to secrete our PTH. The PTH is then going to act at the level of the kidney, and it's going to activate that 25 vitamin D into the 125 active calcitriol. It also stimulates the nephron to increase calcium resorption and increase phosphorus excretion. Why is that important? That's important because when PTH and vitamin D act to break down bone, demineralize bone, it's doing this to drop calcium into the serum. Remember the stimulus. How is this process initiated? What is the stimulus for PTH and active vitamin D? It's a drop in serum calcium. However, once we demineralize bone, recall, demineralizing bone is breaking down that hydroxyapatite, which is both a calcium and organic phosphate matrix. So in order to raise serum calcium by demineralizing bone under the signal of PTH and active vitamin D, calcitriol, we are going to be dropping both calcium and phosphate into the serum. Therefore, it makes sense that the kidney, because remember, our bodies are brilliant. It knows exactly what it needs to do for balance and homeostasis. So under the direction of the PTH action on the nephron, it saves calcium. So the signal is to increase the nephron's resorption of calcium. So we save more of it versus some of it remaining and filtrate to become urine. But then we increase how much phosphate becomes filtrate and does not get resorbed, which means we are saving calcium and we are forcing phosphate into urine, because if it's not resorbed from filtrate, it is urine. So the process is a drop in serum calcium so that we can save calcium and excrete phosphorus. So how is it stopped? Very important. This is a feedback mechanism. Once the calcium rises, we do not want to keep having PTH and vitamin D acting to break down bone. So as soon as the calcium rises, it stimulates the antagonistic thyroid hormone, calcitonin. When simultaneously the phosphate rises, remember, break down bone, demineralization of bone under the stimulus of PTH and active calcitriol, that's going to drop both calcium and phosphorus into the serum. So the kidneys are going to make one control point. It saves calcium, it excretes phosphorus. Once both calcium and phosphorus rise, we have two mechanisms to halt the demineralization, to inactivate vitamin D. Calcitriol gets inactivated, and then simultaneously we are going to stop the parathyroid gland's secretion of the PTH hormone. So there are two mechanisms. Once you have a rise in serum calcium, it activates, pay attention, the thyroid. The thyroid secretes calcitonin. This is an antagonistic reaction. Once serum calcium rises, that is how we halt the demineralization. This is the antagonistic feedback loop. So a rise in serum calcium is going to activate thyroid secretion of calcitonin. Calcitonin is going to act on its adjacent parathyroid and tell it to stop secreting PTH. Remember, the parathyroid sits on top of the thyroid. They are adjacent to each other. So that's a parahormone type of reaction. Once the phosphate rises, we have a activation of the fibroblastic HC03, which is going to be from the osteoblast. So a rise in phosphorus because of the demineralization is going to activate the fibroblast growth factor 23, FGF23. This is going to degrade and inactivate calcitriol. It also independent mechanism assists in increasing the excretion of phosphorus to make sure that we don't end up with hyperphosphatemia. Okay, so that's how it is stopped, that's how it is initiated, and those are the hormonal regulatory actions that you need to know. So the feedback loop is physiologically established, and what happens if it's dysfunctional? Why is this feedback physiologically established? It is because we are tightly regulating calcium. The signal is rise in calcium, a drop in calcium to activate it and a rise in calcium to deactivate it. However, there's a secondary mechanism, as we just said, that if phosphorus, as phosphorus rises, we also have the FGF. So what happens if it's dysfunctional? If you cannot stop demineralization because of active vitamin D and active hypercalcemia acting at the hypercalcemia is then going to if it's not responding, we can have an increased demineralization of bone. And if hypercalcemia kicks in, then you have some of the agitating second messenger effects, which can agitate smooth muscle as well as a cardiac muscle, because cardiac is definitely smooth muscle. So what causes remineralization? So we are going to remineralize with our vitamin D and vitamin K. So the vitamin D under the vitamin K with the direction of vitamin D actually works to increase the calcium uptake. And we're going to recognize that that is a vitamin K dependent carboxylation reaction that allows the calcium to be taken out of serum and to be rebuilt into a calcium phosphorate hydroxyapatite matrix. And then that's under the direction of vitamin D. So we need to remineralize with vitamin K and vitamin D. So why is measuring calcium and phosphorus important from the perspective of bone, calcium homeostasis, and renal function? Because if we monitor a CMP, we need to see if we are well, of course, calcium is the only one on a CMP, but we can also monitor phosphorus as an add-on, because we do not want osteopenia or osteoporosis because of impaired signaling and excessive bone demineralization to try to manage calcium. Renal function is important because, of course, we need to make sure that our body is appropriately resorbing and or excreting the calcium and phosphorus under the regulatory signals. So somebody in renal function, renal failure or renal insufficiency, they're going to poorly form filtrate. If you can't form filtrate, then you are going to have excessive solutes and electrolytes in the blood, and then that could cause a hypercalcemia or a hyperphosphatemia if you cannot get these into filtrate. On the opposite end, if you get them into filtrate, but then your nephrons are dysfunctional, then you are not going to be appropriately saving calcium or losing phosphorus. So you can end up with a hypocalcemia under impaired nephrons and a hyperphosphatemia under an impaired nephron because of the resorption and absorption issues. Same thing, calcium homeostasis. If these are not properly working, then we're going to have an imbalance in the hypercalcemia. Hypercalcemia is a problem. Almost never are you going, I don't want to say never, that's not a good word. Very, very rarely do you have hypocalcemia. Now, somebody who has significant renal failure could potentially, and it's, they're not under a dialysis and remineralization therapeutically, then they could have hypocalcemia, but it's very rare because of the tight regulatory mechanisms. Albumin is one of the primary transport proteins of the calcium. So if you have low albumin, which again could be potentially like liver failure in someone who has cirrhosis or fibrosis, because the liver has to synthesize the albumin, then of course you won't have enough of a carrier. But almost always hypocalcemia is very rare. However, hypercalcemia is a significant sign that there could be a parathyroid adenoma. And if you have hypercalcemia on a CMP, you have a parathyroid tumor, adenoma until proven otherwise, and your immediate reaction is to refer that out for a ultrasound. You do not sit and start asking questions. Do you take calcium supplements? A lot of older, post-menopausal women think that they have to supplement a lot with calcium. They can have a pseudo hypercalcemia. However, if they're symptomatic with fatigue and low grade generalized fatigue and irritability, that's most likely going to be a hypercalcemia coming from a parathyroid tumor, and you need to get them immediately referred out for an ultrasound. Okay, what is hyperphosphatemia associated with? Very important, because phosphate and hyperphosphatemia is very overlooked, and excessive soda intake, which is part of our Western diet, is going to be a problem, because soda is a very high dietary source of phosphoric acid, and we can end up with hyperphosphatemia. One of the things that will happen with that is an increased risk for arteriosclerosis. Arteriosclerosis, which is calcification of the arteries, is the same calcium phosphate hydroxyapatite crystal that we need for our teeth and our bones. However, under the direction of vitamin K, and a vitamin K dependent carboxylation reaction is going to kick calcium out of the arteries. So if somebody has hyperphosphatemia, there's a greater chance that that excessive phosphate can come into contact with a free calcium in serum, and it can get stuck and uptake into the arteries. If somebody has both hyperphosphate, again, be thinking somebody who drinks an excessive amount of soda, plus their vitamin K deficient, who's almost everybody. But if you take a high dose high dose over the counter aspirin or a warfarin, or if you take high dose, I didn't mean high dose aspirin. Aspirin, even baby aspirin, is sufficient enough to inhibit your vitamin K. So the physiological function of vitamin K is carboxylation reactions, and it has to do with binding a calcium. So the carboxylation is binding of a calcium. So somebody who has both deficient vitamin K is not going to be able to sufficiently kick the calcium and out of the arteries under the protective mechanism of preventing arteriosclerosis. So if you have the combo of high soda, hyperphosphatemia, plus inefficient or deficient vitamin K, you're at serious risk of having arteriosclerosis. So the other common vitamin that we need to worry about is a deficient vitamin K. The dietary source was high soda in our Western diets, and it's associated with arteriosclerosis. So why would renal failure cause hyperphosphatemia? Because if the nephron excretes, meaning it pushes the phosphate into urine, and then it saves the other, it saves the calcium, it saves sodium. So if you cannot efficiently excrete phosphate, then you can also end up with acute renal failure or acute renal insufficiency, having a hyperphosphatemia. And then how does end organ renal failure differ? That person is on dialysis, and they cannot form filtrate, and they cannot concentrate urine. So they are at a high risk of having imbalanced, especially if they're not on dialysis and they're already in end organ renal failure. Remember, that's stage 5. So if someone drinks a lot of soda, what other supplements should be provided to protect the arteries? And of course, that is your vitamin K, especially your K2, menaquinone. Remember, your menaquinone, which we will analyze down here, is going to be K2. K2 acts at the level of preventing arteriosclerosis and preventing osteoporosis, because we will find that the vitamin K dependent carboxylation reaction, just like it kicks calcium out of the arteries, it actually takes calcium into the bone to help build the hydroxyapatite, as we had said, with remineralization. So we need to make sure somebody who drinks a lot of soda should be supplementing with vitamin K, especially K2, because K1 is primarily for the hepatic clotting cascade. So why is calcium and phosphorus associated with arteriosclerosis, and why is vitamin K? So that we already answered that. Why does vitamin D do, what does vitamin D do to renal regulation of nephron resorption? Okay, so under the direction of the activated vitamin D, active vitamin D is your 125 calcitriol. So the parathyroid hormone at the level of the kidney, first it activates vitamin D, forming active calcitriol, and then it also acts at the level of the bone for resorption. However, the vitamin D is going to actually act on both the small intestine to increase calcium absorption, assimilation, but then it also, along with PTH, is going to be part of the vitamin D demineralization. However, vitamin D does not directly act on the nephron. It does not act on the nephron per se. That is your that's your fibroblast growth factor to increase phosphate excretion, and it's your parathyroid hormone to increase calcium resorption and increase phosphorus excretion. And let's see. Oh, and calcitonin, which is your antagonistic hormone to a rise in calcium, will also act at the level of the nephron to decrease calcium resorption, so that we will take calcium resorption back down to normal physiological levels, away from that enhanced calcium absorption under the direction of PTH, because remember, it's an antagonistic effect. Okay, so what is the form of vitamin D regularly tested? So this is important because we want to make sure that we have the the 25. That is the vitamin D that is typically measured, and we want the vitamin D to be tested at the 25. So the difference is, if you had a special test, the 125 calcitriol has a very short half-life and it has a different range. When we're looking at the normal vitamin D that we test, we are testing the inactive form of the vitamin D hydroxycalcitriol. So we want optimal levels of 70 to 85. Remember, 32 is approximately what we call vitamin D deficient. So what is the special vitamin D test? The special vitamin D test is active calcitriol. That is not your normal range, a normal test. So the optimal range was your 70 to 85, and that is what I want you to know. What is deficient? Anything below 32. Anything below 32 is deficient for vitamin D. And once you get below 20, that is called severe vitamin D deficiency, and that is associated with all mortality, increased rates of death. Very important. Every disease will be aggravated, and mortality will increase if you get into severe deficiency, which is in the low 20s. Why is optimal physiological vitamin D important for immune regulation of self-tolerance? Vitamin D is associated with the immune stimulation of the anti-inflammatory and anti-autoimmune interleukin 10. Interleukin 10 is secreted by the Tregs, and it is under the direction of vitamin D. Once the Treg is activated with the anti-inflammatory interleukin 10, it will then promote the T sub 0 before a T cell, immune cell, becomes a dominant 1 or a dominant 2 under the direction of different cascades and cytokines and leukotrienes. The Treg and T0 subset is where interleukin 10 promotes self-tolerance. If you don't have sufficient levels of interleukin 10 being secreted by your population of T regulatory cells, you will lose self-tolerance and you are more prone to autoimmune activation. So vitamin D is very important for self-tolerance and T-reg and T0 populations, and that's under the direction of your vitamin D. Why is optimal physiological levels of vitamin D important at the level of the epigenetic genome? Now, this is important because this requires vitamin A. In order for the VDR, which is your vitamin D receptor, plus there's a VDR gene, vitamin D receptor gene, the immune cell and 17 different cells have been shown to be able to activate vitamin D for stimulating active physiological roles. This is called pleiotropic. Vitamin D and vitamin A together have a pleiotropic effect, meaning they have physiological functions beyond just their role as a vitamin. And in vitamin D's case, that's beyond, calcium homeostasis and bone status. So vitamin D, VDR, plus a vitamin A, RXR, they form a heterodimer. This heterodimer works at the level of epigenetic expression of the VDR gene, allowing the VDR gene to be synthesized. And this heterodimer is also important for the immune cells to properly be activated when they need to launch an attack. So you can imagine in this day and age of the corona, pandemic, people need to be both vitamin D and vitamin A sufficient. If you feel a cold or a sniffle or a sore throat or a fatigue or a body ache coming on, the best thing to do is 3 days of high dose vitamin D plus vitamin A. And you can only do this short term. You can only do this 1 to 3 days. And I would do 100,000 IUs of vitamin A paired with 50,000 IUs of vitamin D. That is an insane supra physiological dose, and you push it in, it will be taken up at the level of the genome. It will help form the heterodimers. It will help your genome be able to synthesize the VDR, synthesize the RXR, and it will help your immune system go to town fighting whatever exposures you have. You cannot stay at that dose. That is literally 1 to 3 days. However, that is an excellent way, clinical pearl, to make sure that you are supporting that is not a test question, that is a clinical pearl, especially with what we're experiencing in this 2020 craziness year. You cannot stay at those levels. A maintenance dose could be 5,000 for vitamin D, and then I typically do 25,000 vitamin A once a week as a maintenance dose. Otherwise, you don't take that regularly. Which vitamin K is important for the clotting cascade? We already said that's your phyloquinone, which is your K1. And K2, which is your menaquinone, protects your arteries from arteriosclerosis and your bones from osteoporosis because of that vitamin K dependent carboxylation reaction. The active physiological function of vitamin K is carboxylation reactions, which is binding a calcium and putting it into whatever location it needs through that carboxylation reaction. So osteocalcin is going to be a small protein, and it works at the level of the bone. And this again is where the vitamin K dependent carboxylation action reaction is working. So the osteocalcin under the direction of a activated vitamin K, will add a calcium under a carboxylation reaction and drop it into a hydroxyapatite. And that does so under the direction of the vitamin D acting on the osteoblasts. So osteocalcin is a vitamin K dependent carboxylation reaction, which uptakes calcium and puts it into the hydroxyapatite matrix. Okay. What medications can cause a problem? So there are there's one medication, there's one over the counter, and then there's one natural agent, and you need to know all three. Your population of blood thinners, which is your warfarin and Coumadin, has the same physiological function as your over the counter aspirin and ibuprofens, because that's a salicylic acid. And then even baby aspirin is enough to do this mechanism we're about to discuss. However, because white willow is a natural source of salicylic acid, it too, when it's greater than 750 milligrams in one dose, all of these have the same mechanism of action. And what it is, and you need to know this, it inhibits the recycling of vitamin K. If you do not actively recycle vitamin K after each carboxylation reaction, delivering the calcium, it will become inactive. The reason a blood thinner works is because it inactivates vitamin K. So does aspirin, so does white willow greater than 755 milligrams in one dose. Can you take 300 in the morning and 300 at night? Absolutely. And you will not inhibit vitamin K. If you take a 750 or 100 milligram dose, you are mimicking a baby aspirin, and you will be inhibiting vitamin K. Now, could you take a patient who wants to come off the Coumadin, or who wants to not do the baby aspirin? You can use a 1,000 milligram white willow, and it will be a natural minor blood thinning benefit, because it mimics the inhibition of the vitamin K recycling. However, it will have less side effects, which is the positive of the aspirin over the counter or your prescription Coumadin, because it's the same mechanism of action. However, you still have to supplement low dose vitamin K, because they are prone to osteopenia and osteoporosis. And they have demonstrated in current day medical literature, they have raised, relieved, removed the ban of patients on Coumadin who are normally told to not eat green leafies and not supplement with vitamin K. They have retracted that. They want the patients at a different time of the day taking a low dose vitamin K, because they know because they have to restore this mechanism, especially of the K2, because they were finding that the Coumadin population were significantly prone to osteopenia and arteriosclerosis, because you can't inhibit vitamin K and not have any of its downstream effects. And there are some really great documented literatures for that. Okay, so make sure you know those three. What is the natural agent? Okay, we just talked about that. What is the dose? Greater than 750 in one dose. All right, so now how do you test? This is important. So now you understand the mechanisms of what we're looking for when we're testing vitamin K and vitamin D. So the vitamin K tests are protein S deficiency and undercarboxylated osteocalcin. Those are your two tests for vitamin K, protein S and undercarboxylated osteocalcin. If either one of these are elevated, it indicates low bioavailable vitamin K. That means that there are not enough, it's either not enough vitamin K or there's not enough of the active form. Both of these will be elevated, indicating a vitamin K deficiency. So the test that you can use for bone DEXA, in alternative to the DEXA scan, is going to be the bioimpedance. If you have a bioimpedance, you will have a it's within 3% as accurate as a DEXA scan. So that's a great way to test bone. Your vitamin D was your 25, and then the special vitamin D test was the 125, which is your calcitriol. Okay, let's take a look at fluid dynamics and acid base. Okay, so we already mentioned that phosphorus and calcium are macrominerals, non-electrolytes. However, on a standardized CMP, we have calcium, but we do not have phosphorus. So then we need to recognize what are the electrolytes. Your electrolytes are the three macrominerals, and that is your sodium, chloride, and potassium. Sodium, chloride, and potassium. However, renal function is associated with analyzing all of the minerals. The CMP electrolytes are only the sodium chloride and potassium. And the reason these are electrolytes is because they are directly involved in fluid dynamics as well as blood volume. Blood volume is how much fluid is in your blood vessels, which is the direct correlation to maintaining blood pressure. So if someone is not managing their nephron resorption excretion ratios of the electrolytes, it can have a significant impact on blood volume and a negative impact on hypertension and blood pressure. So it's in my opinion that majority of doctors do not analyze the dehydration and or mineral insufficiency and acid base. They go right on a blood pressure hypertension lowering drug, and then they never consider just doing some minerals and hydration therapy first, which I think is criminal. So be better than that, and make sure that you recognize that not only are there electrolytes is super important for renal function as well as hypertension and blood management through the effect on blood volume. However, our minerals also mop up acids. Acids are your H plus hydrogen atoms. That's acidity. So we can use different electrolytes to help manage body acidity, another really important function of electrolytes. Okay, so why is the renal function indices on CMP correlated to minerals and electrolytes? Because they are under tight regulatory control. Just like your calcium under PTH and vitamin D, calcitonin, and fibroblastic growth factor 23, we have multiple hormonal regulatory feedback loops that manage water as well as the minerals. So why does the GFR correlate to toxicity? Now, this is as well as minerals and electrolytes. So this is super important. 22% of cardiac output from the heart goes directly into the renal artery and goes therefore directly into the kidney nephron. Once the blood goes into the glomeruli, which is the Bowman's capsule, it forms filtrate. Filtrate through the remainder of the nephron is going to then be under controls of your proximal and distal convoluted tubules and your loop of Henle. Those are your control points where we resorb nutrients. If you do not have a nephron mechanism to resorb the solutes out of the filtrate, which is formed from that 22% of renal artery going through your glomeruli at the kidney, anything that is not resorbed through the control points of the nephron remains in the filtrate, which is urine. That is one of the most important mechanisms of excretion. Recall 4 routes of excretion: urine through filtrate, fecal matter through bile, you have sweat, which is through an ionic exchange, and you have breath. So different molecules can be excreted through one of the 4 routes. Therefore, the benefit of a functional and optimal GFR, glomerular filtration rate. Remember the 3 indices when we analyze renal function, you have to analyze GFR, BUN, blood urea nitrogen, and creatinine. Under a high efficient rapid GFR, that means all of the crap in all of the solutes, all of the xenobiotics that are conjugated from the liver marked for excretion into urine, all of the urea, which is that's a nitrogenous metabolic waste to make sure that we don't end up with toxic ammonia. That is super important. This is how we eliminate wastes and foreign substances rapidly. Therefore, if you have a low GFR, acute renal insufficiency, or renal failure, or even worse, end organ failure, renal disease, dialysis, you are not forming filtrate. If your GFR decreases, you have more toxins, you have more metabolic waste, you have more xenobiotics, you have more conjugated phase 2 molecules from the liver detox phase not being excreted. The other problem with that is if you cannot save calcium, if you cannot save sodium, you cannot save magnesium, what are you doing? You're losing those to urine. However, you're going to end up with low sodium, low calcium, low magnesium, and then we should be excreting we should be excreting phosphorus and potassium. So what additionally happens is you end up with hyperphosphatemia and hyperkalemia. So if you have an impairment of your GFR, you are toxic to ammonia, you are toxic to conjugated molecules and bilirubins and conjugated xenobiotics from the hepatic detox pathways, and you are in a complete imbalance of electrolytes. So if someone has renal insufficiency, what happens? That's what I just discussed. If someone has renal insufficiency, what happens to toxins and body burden? So the body burden increases and your mineral electrolytes become dysfunctional and imbalanced because of impaired rates of excretion versus resorption. So why is adrenal secretion of aldosterone correlated to kidney function and other renal function tests on the CMP? Aldosterone is going to be the hormone that influences the resorption of the sodium. Under the RAS, RAAS, renin-angiotensin-aldosterone system, that is how we respond to changes in blood volume. A drop in blood volume stimulates RAS, and then the end result is aldosterone is secreted from the adrenal gland to act on the nephron to save sodium. Why? Sodium, water follows. Water, sodium follows. Those two are very intimately correlated in fluid dynamics. So if you have a drop in blood volume, think about dehydration. Dehydration pulls fluid out of the cell, shrinking the cells, and then it also raises the solute concentrations, and then it stimulates RAS, and then we're going to secrete aldosterone, and it's going to increase. It increases how much sodium we resorb. Now, the alternative that happens, or excuse me, not alternative, but the simultaneous, when we activate aldosterone to save sodium, we increase the excretion rate of potassium. Now, very important, make sure you recognize this. There are no mechanisms at the level of the nephron to save potassium. The nephron does not resorb potassium. That means if you have aldosterone activated on the nephron to save and resorb more sodium, in response to a drop in blood volume, we are saving sodium and we are losing even more potassium. So we don't save it, and then under aldosterone, we lose even greater amounts of potassium. So that would be more of a hypokalemia. So what does aldosterone do to the nephron? So we said that it saves sodium and it excretes potassium at a higher rate. To calcium and phosphorus, aldosterone does not act on calcium or phosphorus. What are the three mechanisms to regulate blood pressure? Okay, so we mentioned that we have the RAS. The next one is going to be your natriuretic peptide. That's going to be the antagonist to aldosterone. And then we have ADH. So RAS, which ends with the secretion of aldosterone to save sodium. When sodium is going to drop, we actually have the heart, which secretes your natriuretic peptide. So aldosterone and the natriuretic peptide act on sodium. And then the ADH is that saves water. So antidiuretic hormone, which is also called vasopressin, at the level of the kidney nephron, it activates the aquaporins, and it will save and conserve water. It will save and conserve water. So that's the three mechanisms to regulate blood volume and hence blood pressure. So if your patient drinks, and pees, what's happening? And if you ask patients this, you will find out this is actually quite common. A person who is thirsty and cannot drink enough water without immediately urinating it out, that's a functional signal. That's a physiological functional signal that there is a adrenal fatigue. Adrenal fatigue is going to mean that they are not secreting sufficient amounts of aldosterone. Adrenal fatigue means that the adrenal gland, who secretes your corticosteroid cortisol and your mineral corticoid aldosterone, it means that the adrenal gland under adrenal fatigue is not functioning properly. And if you don't secrete enough aldosterone, you will actually lose sodium. And if you lose sodium, because remember, aldosterone saves sodium through resorption, then if you are not preserving sodium, water follows. So someone who is thirsty and they drink, and they pee, that is not enough aldosterone, and that is a sign of adrenal burnout, and that's your clinical pearl. So the problem with sodium is that when you are looking at hypo versus hypernatremia, if you have high sodium or too low of sodium, they both can result in significant neurological symptoms, seizure, and coma. So hypernatremia is almost never too much salt intake. Too many people avoid salt because they think that that is going to change their blood pressure, when it's really more dehydration and imbalanced other minerals. Almost always hypernatremia, meaning too much sodium, is going to be from an imbalanced water. It's normally not, because remember, equilibrium of a solute, which is something dissolved inside a fluid, that's equilibrium. So if you have too little of the fluid, it will look like a relative increase in the dissolved components. So you would have a relative elevated increased solute, but it's not real. It's a false relative increase because of not enough fluid. So almost always your hypernatremia is due to dehydration. Speaking of dehydration, very important is the what does dehydration look like on your CMP? I know I have this coming up. I don't know if I passed it, but make sure that you know this. Dehydration is going to be a combination of, let's see if I have it somewhere. Dehydration is going to be a combination of increased solutes plus, so you're going to have high sodium, it's going to have high potassium, you're going to have potentially high protein and high albumins, because those are dissolved solutes and dissolved constituents. If you have significant dehydration, the things that should be dissolved are going to all of them together have to be high. And then you need to look at a CBC. On your CBC, along with elevated protein, albumin, and electrolytes, you're also going to have elevated hematocrit and RBC. Why? Because red blood cells are dissolved in the fluid, and the hematocrit is the red blood cell portion of the blood. So you would have elevated hematocrit, elevated RBC, elevated protein, elevated albumin, and elevated electrolytes, because those are all solutes. And then that's going to be relative highs because of not enough water, dehydration. Okay, so remember that potassium is not going to be resorbed. What mineral deficiency aggravates the potassium? And that is going to be magnesium. So if you have a magnesium deficiency, it will aggravate not only potassium, but it will aggravate your calcium as well. And I think that was somewhere up here under potassium. So magnesium deficiency is going to aggravate both potassium and a calcium deficiency. What diagnosis and its medication is a risk for hyperkalemia? And that is your blood pressure. That's your potassium sparing hypertension meds. Okay, so getting into acid base. So we need to remember that on the CMP, when you look at the carbon dioxide, The carbon dioxide on a standardized CMP is not the gaseous carbon dioxide. It is actually bicarbonate. Bicarbonate is a negative anion. Important, negative anion. The bicarbonate is going to be a direct result of metabolic waste of the tissues, as carbon dioxide is the end product of the electron transport chain after oxygen is taken up from the red blood cell, goes through the electron transport chain, interacts with coenzyme Q and your reducing equivalents, B2 and B3. And then through all of that, we get ATP to fuel cellular processes, along with the metabolic waste product, carbon dioxide. Carbon dioxide will diffuse back through the interstitial fluid and then get back into the serum and react with the red blood cells' zinc dependent carbonic anhydrase. The zinc dependent carbonic anhydrase is a rapid dissociation of carbon dioxide gas into the bicarbonate negative anion. Therefore, this is a direct measure of acidity in the blood from the metabolic waste product. Once the bicarbonate reaches the lungs, it goes back through that reversible reaction, will become the gaseous CO2 again, and we will exhale it. However, while the bicarbonate is traveling either in serum throughout the rest of the peripheral body outside of the lungs and or the red blood cell, it's one of the most potent buffers for acidity. So how do we measure acidity on the CMP? It's the carbon dioxide, which is a direct measurement of bicarbonate. What is it not? It is not gaseous CO2. We definitely want to alkalize with potassium and magnesium citrates. The citrate is very beneficial as a negative anion, and the negative anion is what mops up acids. Picture here, the bicarbonate with the negative will scoop up an acid and prevent acidity. The citrate is a negative anion, and it will do the same thing. So potassium and magnesium, along with the citrate, each one of these are beneficial in mopping up acids and preventing acidity. This is the one that I like, which you already know. And you can also use baking soda, which is sodium bicarbonate, to achieve the same alkalizing benefit. However, go with a low dose, because if you go higher than a quarter teaspoon at a time dissolved in water, it can cause a significant bloating in the belly, and it can be it's uncomfortable. So if you alkalize in between meals with the baking soda, Clinical Pearl, you will be able to have you'll raise your blood alkalinity, probably up to 7.5, 8, 8.5, and then your kidneys will rapidly excrete the either ammonias, and then you have a wonderful alkalizing benefit. I learned from a very one of my favorite people in the whole wide world, which is Dr. Alex Vasquez, who holds a DCND DO degree plus a master's. The man is brilliant. I learned from him that anytime he has brain fog or is having concentration problems, he'll go alkalize himself with simply using baking soda. And he normally says within a few minutes, you can literally feel the clarity as you clear out the acidity. So super important. Glutamine, I'm not testing you on this. Again, this is under a Clinical Pearl. Glutamine is really fabulous at the level of the kidneys, and the kidneys use it as a buffer to also get rid of extra acids. Okay, so that was acid base, and then analyzing CMP with some of our macro minerals and macro mineral electrolytes.